Hello and welcome to Let's Talk Health. Today we are on the 15th edition of Let's Talk Health. This is a program which is being done by Star Hospitals. We deal with common conditions which are affecting general public. We involve surgeons and physicians in different specialities and try and address common problems which are being faced by the public. And today I am Dr. Shashi Kanth, Senior Consultant Orthopedic Surgeon. And we have today with us Dr. Rohini. She is a senior endocrinologist at Star Hospitals. Today, we are going to deal with diabetes and its implications in orthopedic practice. So, Dr. Rohini will be talking to us in detail about diabetes, and I will be talking to you about the orthopedic problems of diabetes. So, welcome, Dr. Rohini.
Hi, sir.
Hi. So, Rohini, we talk about diabetes, it is a common problem which people are facing, and there is a big economic burden on the society. So, how do you see diabetes as a problem in the next coming decade or so?
Actually, we have already seen a big change in the incidence of diabetes, sir, honestly speaking. Before it used to be like so there's two common types of diabetes, type 1 and type 2. Type 1 is the autoimmune kind, which typically happens in young patients, which is like childhood or teenage years typically. And they need insulin because it is autoimmune, but the pancreas is damaged because of immune attack. Type 2 diabetes, which constitutes more than 90% of diabetes, is what we are going to talk about today. Okay. So this diabetes, we used to call it middle-age diabetes. Okay. It used to happen more in like 40s and 50s. Yeah. But here lately, we are seeing 30s and 20s, age group being affected by typical type 2 diabetes, which we used to be a middle-age disease. Okay. Now it's also becoming a young patient disease. Okay. So I see that the burden is only going to increase, sir, if we don't do anything about it as of right now. Okay. If we don't pay attention to our lifestyle and exercise, I only see it getting worse day by day.
Yeah, that's a good way of putting it. And one simple question which people usually common ask is, who is a diabetic? Let's say, is it based on a fasting sugar or is it based on this test called HbA1c? What does the WHO say? Who is a diabetic?
So it's actually both. We look at we can look at fasting blood sugar. We can look at hemoglobin A1c. We can also do a glucose tolerance test. Okay. So if we look at fasting blood sugar levels, normal fasting blood sugar level is less than 100. Okay. So if your fasting blood sugar is anywhere between 100 to 125, then it is pre-diabetes. Okay. Once it crosses 126 or above, it's called diabetes. Okay. So just with a simple fasting blood sugar, you can have an idea of what your sugar is or where you stand in this spectrum. Yeah. And if you take a hemoglobin A1c standpoint, a normal hemoglobin A1c is less than 5.7. Okay. Okay. Between 5.7 to 6.4 is pre-diabetes. Okay. And once it crosses 6.5 and above, it's called diabetes. Okay. And coming to the glucose tolerance test, which I mentioned, typically we do this more in gestational diabetes in pregnancy. Yeah. Because it's a more cumbersome test. It takes a couple of hours to do this test. Okay. First, we draw a fasting blood sugar. Then we give the patient 75 grams of glucose to drink. And then after that, we draw blood again after 1 hour and 2 hours. Yeah. And based on the cutoffs, we decide whether this is, pre-diabetes or diabetes. Okay. If the 2-hour level crosses 200, it is called diabetes. If it is between 140 to 199, it's called pre-diabetes. Okay. Below 140 is normal. Okay. At 2 hours.
Yeah. Once you probably diagnose your patient as a diabetic based on these criteria, when would you start treatment on these patients and what type of treatment would you give?
So basically, the treatment starts right away. Okay. And the treatment at any given point of time from the start of diagnosis includes lifestyle changes as a strict bottom line. Okay. That's the background. Yeah. And any medications will be on top of the lifestyle management. Okay. So even if you are in the pre-diabetes range, we emphasize a lot of lifestyle changes and sometimes even starting medication in the pre-diabetes phase, so that way it does not progress to become diabetes. Okay. So we start with lifestyle, diet changes, exercise and weight loss, focus on weight loss, and then medications as and when needed. And different kinds of medications are now available. Okay. And ultimately different types of medications, tablets and injections, and there are also insulin as an option at the end.
Okay. And I mean, we see a lot of patients with diabetes who land up in our orthopedic clinics as well. And one of the most common problem which we see is basically a frozen shoulder.
I have a lot of patients, sir, that have frozen shoulder.
Yeah.
So please tell us a little more about the frozen shoulder, how it presents and what to do about it.
Yeah. So frozen shoulder is typically a problem mainly affecting diabetics. But having said that, there are about 10% of patients even with diabetes who come in with a frozen shoulder. And as the name indicates, there is basically restriction of the shoulder movements. That is what technically people have. They usually complain of about pain, then they complain about stiffness, then they have a combination of pain and stiffness, and ultimately they feel it's a disability with their daily living. I mean, any activities of daily living, like they have to pick something from the top shelf, like for housewives, or they have to take out their clothes or put on their clothes, they usually have discomfort. Some people have pain that wakes them up from sleep as well in the night. So basic problem is because of the underlying diabetes, the tissues around the shoulder, they become tighter than normal. And because at the microcellular level, there are changes that happen because of the glycosylation of glycosylation, and the tissues become more tighter than normal. So the flexibility of the tissues decreases. So it predominantly affects the shoulder, and usually once we diagnose a patient with frozen shoulder or periarthritis, which is technically called, it is mainly a clinical diagnosis. We don't need an X-ray or anything to diagnose that. But once we diagnose them, then we ask the patient to subject them to a course of physiotherapy and ask them to try and maintain the shoulder movements. Because if they don't do physiotherapy exercises, the shoulder can get stiffer with time. And in rare occasions, people have been advised, if the shoulder movements are really restricted, we do an arthroscopic procedure where we put a telescope inside the shoulder and try and release all the soft tissue so that the shoulder becomes more freer.
Okay.
So these are some techniques which we try and use to try and treat a frozen shoulder patient. But having said that, I mean, as you rightly pointed out, to diagnose the patient immediately and start treatment is the basic line of management. And even in these patients with frozen shoulder, we advise them to control their diabetes also.
Right.
Because uncontrolled diabetes, people have frozen shoulder, we treat them either way, they continue to probably suffer. So in that same construct as to treatment of diabetes which we are talking about, what are the different types of, are there any different types of insulin which you use to treat your patients? Or?
Absolutely. So actually here lately we have had two groups of actually oral agents, sir, that have shown cardiac benefit and renal benefit. Okay? Like according to, they have shown some of these classes of medications have shown to reduce heart failure incidence and reduce the incidence of diabetic kidney disease. Okay. So we are trying to use those agents more often and spare the insulin. Like, you know, insulin is also an option, but once we are exhausted with all these options, then we introduce insulin too. Okay. So we call these SGLT2 inhibitors, and mainly dapagliflozin and empagliflozin and stuff. And they have shown to have kidney benefit and heart benefit. And but the most common side effect with that is urinary tract infection. So again, we have to balance, you know, what are the risks, what are the benefit for each patient. Somebody who comes in with frequent urinary tract infections, we don't use this medication and stuff. And at the same time, we are also focusing more on weight loss, you know, with the treatment of diabetes. We are trying to use agents which can help the patient with weight loss, because ultimately the core is insulin resistance, and, you know, being overweight or obese is the core of problem with the type 2 diabetes. So we are trying to use agents which can help with the weight loss. Lately, GLP-1 agonists have been a big game changers, something called semaglutide, and it is available as a tablet, and injection is not available in India, but other medications in that class are available. So we're trying to use them and try to get as much weight loss as possible. And if these are not getting us to goal, then obviously insulin comes into picture. And it also depends on how long the patient has had diabetes, how much of an improvement we need. If we need like a 4-point reduction in a hemoglobin A1C, then obviously oral agents will not do the trick. We have to start insulin right away. But if it is a 1-point difference, then we can, you know, use lifestyle and another oral agent and stuff.
Okay.
So the other thing that we deal with a lot in our clinic is diabetic feet, sir. So tell me more about what you deal with, and then I'll tell you what about what I deal with.
No, diabetic feet is a very common problem, as we both agree that diabetes itself is a multi-system disorder. I mean, obviously it affects everything. Diabetic feet is a special entity, I would say. Probably it is dealt with a multidisciplinary approach. There are a lot of people who are involved in management of diabetic feet. Back in the Western countries, people talk about podiatry.
Correct.
It's a sub-branch. Obviously, you have been in the US. I'm sure you have known about podiatrists who usually take a lead in dealing with this. They are specialized, probably foot surgeons who usually deal with diabetic feet, apart from the other problems. But here in India, we don't have a branch of podiatry. So diabetic feet, unfortunately, I would say they are either neglected or probably dealt with by everyone. But in an ideal situation, it has to be dealt with a multidisciplinary team. The team should have an orthopedic surgeon, it should have a vascular surgeon, it should have a good endocrinologist, it should have a physiotherapist, it should have a good orthotist and a prosthetist, and a good nursing staff to take care of the diabetic wounds. So in a nutshell, I mean, obviously management of diabetic feet is a big subspecialty in itself. But as I said, in India, I mean, obviously everybody does it. So diabetic feet, they come in different ways. I mean, obviously they can come with, the main problem with diabetes, as you understand, is the problem is there is neuropathy where there is a damage to the nerves. And there is vasculopathy where is damage to the blood vessels, microvascular damage. So what happens in diabetic feet is predominantly because of the loss of nerve supply or the damage to the nerves, neuropathy, people will not have any pain. They have insensate foot.
Correct.
And that is, as you rightly pointed out, based on the duration of diabetes. The longer people have had diabetes, the longer the diabetes have been uncontrolled, they have insensate foot. They keep walking on the insensate foot without proper footwear. That is the most common thing. As you know, in India, people don't want to wear footwear in the houses because they feel it is not right. So, but in diabetes, I think that is something which has to be taken care of, and proper footwear is very paramount. And in this diabetic feet, people usually come with different stages of presentation. Some people come in with a diabetic ulcer. They've been having an ulcer and they say it has not been healing. They come with an ulcer with some discharge from it, and we take X-rays or MRI, and there is osteomyelitis, which is infection of the bone. And obviously they come in with gangrene in extreme cases because as we said, there is involvement of the blood vessels as well. They can come in with the toe gangrene. Some people have two or three toes which are gangrenous, which have come across. So in these situations, obviously we come across different scenarios, either a pure diabetic feet without any problem, but that is the time which we have to catch,
intervene,
and probably start treatment, or people who have an ulcer, or people who have an ulcer with a deformity in the foot. So that is the main area where, as orthopedic surgeons, we usually come into picture. So diabetic foot management, when there is a deformity of the foot, the person or the patient continues to walk on it, and the ulcer gradually gets bigger and bigger.
Correct.
Because they have an insensate foot and they're walking without proper footwear, they usually have an ulcer. In those situations, what we do is initially we give them what is called as an offloading footwear, where the people continues to walk, but there is no pressure on that area. So that will help them with the healing process. And once the wounds have healed, then we go and correct the deformity, because the bones in those areas, because there is no nerve supply and less blood supply, whole of the bones and joints are damaged.
Correct.
And the patient doesn't know about it. That is a problem. That is the main problem. So painless foot, insensate foot, and walking continuously on it. And when the ulcer has healed, we usually do a surgery to try and correct the alignment of the foot.
Correct.
So we put the foot back into the position where it's supposed to be, so that the internal pressure is relieved, and so that the ulcer doesn't form again. And at the same time, we ask them to continue your treatment and ask them to get the sugars under control. So at that point, I mean, obviously you talked about diabetes, and as orthopedic surgeons, we are concerned about our surgeries, and diabetes is the biggest risk factor of infection. So as a diabetologist or an endocrinologist, what would you suggest an orthopedic, any surgical patient to come across would be ideal HbA1c levels? I mean, if it's an elective surgery, what we tend to do is we want the HbA1c to be normal or probably near normal before we contemplate on a elective surgery. If a patient comes in for an emergency surgery, obviously we have to operate and we have to control it. We don't look at HbA1c at that point. So what would you advise with regards to HbA1c levels to be ideal?
So for a patient who is needing an elective surgery, we would suggest anywhere between 6.5 to 7% as a target hemoglobin A1c. It also depends on the patient. Again, it's a case-by-case basis. If a person is a young patient with no major comorbidities, we shoot for a hemoglobin A1c of 6.5%. Okay, that we would say good control. Okay. But if it's an elderly patient and somebody who is at risk for hypoglycemia and somebody who cannot feel the hypoglycemic episodes and somebody with heart disease or a history of stroke who cannot communicate and things like that, then we target the hemoglobin A1c to be a little higher. So we target for 7%. But again, based on the age of the patient, if it's a 75-year-old or 80-year-old, we target a little higher than that. Okay. But elective surgery, we try to, this is even as at baseline, these are the targets. And for orthopedic surgery, again, point of view electively, we try to target that as much as possible.
No. So I think as you rightly pointed out, we surgeons are very worried about diabetes. I mean, obviously our surgeries involves a lot of implants that are placed. We do knee replacement, hip replacement, shoulder replacement. So any patients with a high HbA1c, if you operate, obviously they get infected, and infection is the biggest disaster in orthopedic practice, and obviously diabetes is the biggest risk factor. So we both agree that good control of diabetes is paramount before you go in for an elective surgery, and even for emergency surgeries we should make sure that the sugars are reasonably under control.
That's correct. And most of the time, sometimes what happens is if the blood sugars are not controlled, we immediately start insulin, get it really under good control, and then we go for the surgery, because we don't want to waste too much time, trying to control the sugar with oral agents and, take too much time. So we try to control as soon as possible, so that way the patient can go have the surgery. And again, peri-op, before and after your surgery, the patient's blood sugars have to be very tightly controlled to avoid all those secondary infections that may possibly happen and actually prolong the course of the problem.
And we have talked about control of diabetes, which is probably the main theme of this program. But have you ever noticed that patients are being treated for diabetes with all these tablets, insulin pumps, or whatever we have, and aggressive treatment have patients landed in hypoglycemia? Suddenly, do they become, sugars are very low, and do you come across those problems?
Yes, we do. And hypoglycemia is one of the major side effects of many medications. Most of the time, actually, sulfonylureas, which are the oral tablets, again, they can cause hypoglycemia. And there are some classes which typically do not cause hypoglycemia, which is metformin and DPP-4 inhibitors and SGLT2 inhibitors. These ones do not cause much hypoglycemia, so we try to prefer those agents. But again, if it's not controlled on them, then we have to use the sulfonylureas or insulin. And both of them can cause hypoglycemia. So we just have to be very careful about adjusting the dose of the medications. And sometimes I think patient education is what is more important, because typical hypoglycemia happens in certain situations which are out of the ordinary. Like if they are eating well on time and everything, they don't have hypoglycemia. But all of a sudden they eat out or they get sick with a stomach bug and they start vomiting, they start having loose motions or something, and they continue to take the tablet but not eat. Then they will end up in hypoglycemia. So educating the patient, do not take if you are sick with something, do not take if you take your medication if you are not eating. That actually that education to the patient will prevent most of the hypoglycemic agents. And what to do if they become hypoglycemic is also important. And also I wanted to point it out, sir, in terms of foot care for the diabetes patients. And what I would tell is, every night before you go to bed, examine your feet. Examine your feet before you go to bed every night. And if you cannot look at your own feet, have somebody look at it for you, or place a mirror on the floor and look at it or something. But that is very important, because almost 50% of diabetic patients will have some kind of neuropathy.
Exactly, yeah.
And prevention is always better than cure. So taking care of the problem ahead before it starts is what is important. So examine your feet every night, and if you have dry skin or cracked skin, always moisturize. Do not soak your feet in water for too long. Okay, and the water has to be only lukewarm. It should not be too hot. Okay, wash your feet with water, but do not soak in any kind of water for too long. Okay, and when you moisturize, put some lotion on the top and the bottom of the foot. Don't put it in between your toes, because that will retain the moisture and actually make fungal infections happen more often. Okay, and the other thing
and just to add on that point, with regards to the footwear, with regards to diabetic feet, we usually have a special material called microcellular rubber, MCR chappal. So any patient who has diabetes with some sensory neuropathy, we advise them to use those chappal on a regular basis. So any patient with diabetes with some sensory neuropathy should not walk barefooted at any point of time, so that the chances of these happening will be minimized.
Correct. And that, like you pointed, sir, it's inside the house also you should have to have your chappal. It is okay.
Okay.
And when you go outside, it's best to wear something covered. Okay, like shoes. But most important is the footwear has to be comfortable, like sir said. And it should not be rubbing on any part of your foot for too long, because that's, again, the friction causes the ulcers. And always when you wear your foot, make sure there is no any like sand or pebbles inside, because sometimes when you have neuropathy, you may not be able to feel that there is any foreign body inside the shoe. And that may actually cause irritation and ulcer to your foot. And always keep your sugar under control, and have regular checkups, and make sure your doctor checks for any kind of blood circulation problems, so we can address them ahead of time.
Okay, thank you, Dr. Rohini. It was very informative and a very educative talk. So today we conclude this session of Let's Talk Health. Today we have discussed about diabetes and mainly its implication on orthopedic practice. And we agree that prevention is better than cure, and diabetes is a very common problem. There are a lot of people out there in the society suffering from diabetes. So the message from here is identify and diagnose the diabetes early. Start treatment. See your doctor as soon as possible. Take their advice and follow it meticulously. Don't ignore, or else you will suffer. Thank you, and goodbye.